So the main topic of my presentation today is percutaneous anatomical endoluminal bypass for iliac artery occlusion. It's a very challenging technique. Here my disclosure. 70s male, he was on dialysis, came to our hospital due to left gangrene. CT angiogram disclosed left iliac artery occlusions and below the knee diseases. Of course, we tried to do endovascular recanalization for occluded left iliac arteries. However, this patient had a terrible history. Several years ago, this patient received some of the abdominal surgery due to sigmoid colon perforation, and now he uses some stoma. So during these procedures, external iliac artery was accidentally ligated. Maybe bleeding control or something, but ligated. After that, of course, it's completely occluded. So, in previous procedure, we could not recanalize all of the guideway, could not pass the ligated point. Then we finally gave up endovascular procedure, and we performed femoral bypass, extra-anatomical bypass as an alternative therapies. And additional below the angioplasty was performed, and patient to gangrene condition still improved. However, unfortunately, post-surgical infection was occurred. It's really, really terrible. Of course, we should remove the prosthetic graft to control the infections. However, as you can see, it seemed impossible to recanalize this ligated iliac arteries. All of the guideway could not pass the lesions, so every procedure was failed. What should we do? Of course, another extra anatomical bypass is another option, but I think it's not a good option. So we try to do extreme recanalization technique called PEApass, percutaneous endoluminal anatomical bypass. This is the concept of PEApass. Create proximal and distal AV fistula using an OUTBACK. We try to insert the guide wire into the vein. Next, we try to snare the antegrade wire from the retrograde snare catheter using a retrograde snare catheter. Guide wires externalized, and create a huge AV fistula using a big balloon, Stentgraft debridement, post-dilatation, finish. This is the concept of PEApass. It's almost the same procedure as a PQ bypass for femoral popliteal occlusions. But of course, it's a little bit dangerous compared to the femoral popliteal. Okay, anyway, let's go. So we inserted the 7 French Cs from the left common femoral vein and the left common femoral artery, and 6 French crossover dedicated Cs were also inserted from the right common femoral artery. Here clearly see the occluded, ligated iliac arteries. The first step is try to confirm the nearest point of the artery and veins. We dilate the 12 millimeter huge size PT balloon inside of the vein. As you can see, we can clearly find the nearest point of the artery and the veins. Next, it's a very important step of this procedure. Everybody should see this step. We clearly confirm the L and T position of the OUTBACK and try to confirm the position and ready to go. We finally succeeded in the veins. So you can clearly find the O14 guide wire inside of the veins here. We finally succeeded to create AV fistula using the OUTBACK. Don't move. Sorry, don't move. Okay. The next step is the antegrade site. So, however, unfortunately, the OUTBACK catheter could not pass the crossover point due to the severe calcified iliac artery. So, we try to create the AV fistula alternative technique. We try to puncture the both vessel wall, artery, and veins using O14 high tip weighted penetration guide wire ASAT 40, sorry, and finally succeeded to create the AV fistula in proximal site. Next. After that, we tried to snare the antegrade wire using retrograde snare catheter cell. After the guide wire externalization, we tried to dilate the AV fistula point using a 6 mm balloon. Immediately after the balloon deflation, we immediately deliver the Stentgraft Bi-1. After the Bi-1 deployment, ligated iliac artery flow were completely restored. This is the final angiogram of this procedure. Ligated iliac artery flow was completely recanalized. This is a perfect result. A few days after the procedure, we removed the prosthetic graft, FA bypass graft, and unfortunately, infection was already expanded to the bifurcation of the profunda. So, aggressive debridement were performed, and it seemed impossible to restore the, both SFA and the profunda flow. So, we finally deployed additional Bi-1. Then this is the final angiogram of this procedure. Approximately one month after the procedure, the patient wounds were perfectly cured. It seemed a very nice result. Okay, that's conclusion. Thank you so much for your kind attention.
Definitely a courageous and very good case with good outcomes. Any problems with the vein? Usually the veins are much bigger and they can accommodate the Viabond, but you did not have any problems with the outflow of the vein?
Actually, according to the follow-up CT angiogram, unfortunately, the iliac vein was occluded.
Oh, it was?
So, yes, but so, of course, as you know, so there are many collaterals in the body, so they're not a problem.
So would you suggest, like, if you have to do this again, would people need to be on anticoagulation for some time, or just no need for that?
Yeah, I think, of course, dual antibiotic therapy is needed after the Bi-1 deployment, and so I think additional anticoagulation therapy is, I think, controversial. But so actually, in this case, the vein is already occluded. I think additional anticoagulation.
One more question before I give it back. So.
Yeah.
Pioneer is a great catheter, but the OUTBACK, and I've used it a lot. But why not Pioneer in this case? I mean, you can see the vein, you can see where the vein is closest to the artery by ultrasound, and then you can poke it. It has the same needle. Why the OUTBACK versus the Pioneer?
Actually, in this case, we confirmed all of the artery and vein position using the IBAS. After that, we tried to use the OUTBACK. So I think, of course, Pioneer is, I think, promising, but in Japan, Pioneer is not reimbursed. So,
Pioneer is like the OUTBACK, just have the ultrasound on it, right?
I think it's a great idea.
Any others?
What size stent was used? What size Viabond was this?
8 millimeters.
8 millimeter.
How do you manage the antibiotics after this? Having dealt with groin infections myself, they are definitely a problem and very challenging. And then you're always stuck with what to do with more prosthetic when you effectively when you have an infection. I mean, sometimes you can't avoid it, right? But now that we have put more prosthetic there, what is your thought on,
It's a very difficult point, actually. But in this case, there's no way to recognize this iliac artery. So, of course, once the infection was recurrent, so it's a situation is more critical, but it's very difficult.
I just have a question for Dr. Sai. So, from a surgical standpoint, can you elaborate how this external iliac was accidentally ligated? How would that happen?
She doesn't do that. She cannot comment on it.
That's one of the
That's not
reasons.
something she does.
That's one of the reasons I went into vascular surgery, was not to have to deal with that. No, it happens actually when you have somebody with, bad sigmoid diverticulitis. Everything is very socked into the left lower quadrant, and people, it's so inflamed. You're going across the mesentery. Usually the patient's very sick. It's usually like a ligature or some other sort of coagulating device, and the next thing you know, the external iliac has been, ligated. It happens.
Yeah.
Yeah.
It happens. Well, thank you.
Yeah, thank you so much. Yeah.
Thank you.